Hello, students. Here we are on moving forward to um, the immune system. All right. So let's talk about live and attenuated vaccines and what is the difference. So, live attenuated vaccines contain live pathogens from either a bacteria or a virus that have been attenuated, which means weakened. Okay. And there are only a couple of them: chickenpox, flu mist, which is the intranasal one that you use, measles, mumps, and rubella, rotavirus, oral polio, and Japanese encephalitis. I'm pretty certain those are the most common um, live and attenuated vaccines that you're going to see out there. So it just means that it is weakened. Mumps and rubella. This is an attenuated vaccine. So it is a live vaccine with a reduced virulence of the pathogen, but it's still viable or live. So attenuation takes an infection agent and alters it. So it's harmless or less virulent. Okay. So the MMR is usually given to children. Um, so measles vaccination at 6 years of age may need to be. Okay. So the rotavirus um, is a monovalent animal rotavirus vaccine, and it helps the body's own immune system to protect against disease. Rotavirus can cause really debilitating diarrhea in the infant, and it should be given at 15 weeks of age. The infant should receive all doses before they turn 8 months of age. If they are beyond 8 months, they're not going to get it. Both vaccines are drops in the mouth. And why don't we want them to have it? After 8 months of age, it increases the risk of intussusception or intussusception of the intestine. And what that means is that the intestine actually um, collapses upon itself, and that's bad. So we don't want that. Let's see, what else do we want to know here? Of course, if the infant had a adverse event with the first dose, you may not get the second one. Also, some of this virus is shed in the infant's stool, so it's important to wash your hands well. It's a good vaccine, but like I said, they've got to get it at before 8 months of age, or it can be really, really bad. So we don't want that to happen. All right. I don't think we need to know anything else about this one. All right. Zoster is really interesting. Several years ago, there was a totally different vaccine than we use today, and it was live attenuated, had to be refrigerated. Now we use a different one. We use Shingrix. And Shingrix vaccine is actually a glycoprotein E, and it is a protein found on the surface of varicella zoster virus. Immune exposure to GE protein stimulates the development of anti GE antibodies. Therefore, it creates an adaptive immunity to shingles, which is pretty cool. Okay, so who should not? What are the precautions with zoster. Of course, if they've had an allergic reaction to the first one, because it's a series of two, they should not have it. Or if they have an acute episode of herpes at the time that they want the vaccine, that's a big no-no. The vaccine is approved for patients over the age of 50. It used to be 65. Now they've lowered it to 6 to 50. And they get one dose, and then 6 months later, they get their second dose. Well, actually, it's 2 to 6 months. So they get their first dose, and 2 to 6 months later, they get their second dose. So they've got that window of opportunity there. I like to advise patients that getting the zoster vaccine does not mean that you will not get shingles. It greatly reduces your risk of developing shingles, but you can still indeed get shingles. It's just like people who got the COVID vaccine and still got COVID. That's just the way vaccines work. They don't give you 100% coverage, and the general population doesn't necessarily know that. So I say that all the time um, when I am giving a zoster vaccine. And I strongly encourage it. I also tell them the first dose, there are very few side effects. Of course, your arm might be sore. The second dose, your immune system really kicks in. At least it did for me. And I felt physically sick that night. My body ached. I felt like I was coming down with the flu. And then my husband said, "Remember, you got that vaccine." And I said, "Oh my gosh, that's it." By the next day, I was totally fine. And again, the same thing about drugs stands for this one as it has does for other live attenuated vaccines. Um, it can weaken if the immune system, if you're using prednisone or cancer chemotherapy, things like that. All right. All right, let's talk about the diphtheria, tetanus, and pertussis vaccine. Now, there are different ones. This one is for young children under the age of, oh, let's say under the age of 8, maybe 10. I'm trying to think because fifth grade they get the Tdap. This is a D tap, I guess, or whatever you'd call it. Um, the diphtheria, tetanus, and pertussis vaccine. So it's different than the Tdap. But this is a combination vaccine. It consists of diphtheria and tetanus toxoids. They're inactivated, and acellular pertussis antigens. The tetanus component of the vaccine um, is probably, oh, we don't need to know that part of it. The vaccine produces an active immune response of the body by developing antibodies and antitoxins against the toxoids and acellular pertussis antigens. Now, typically, an infant will get this at 2 months of age. The minimum is 6 weeks. And then they'll get the second dose at 4 months, the third dose at 6 months. Then they'll get a dose between 15 and 18 months. And then 4 to 6 years. That'll be the last dose. Okay. They will, and then they get the Tdap, which is different. It's a different formulation. And they can get swelling and redness at the site. You can get that with all vaccines. Of course, we always worry about those adverse events that can occur in some children, like seizures and hypotonic, hyporesponsive episodes, prolonged crying. But those are rare and hopefully won't happen to any of your patients. Ba 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 ba. Let's see. All right, I think that is a pretty good overview of the diphtheria, tetanus, and pertussis vaccine. This is not live. Okay, this is a dead virus. And this is a super important one. Once the patient gets to be in 5th grade, they get the Tdap, which is the tetanus, diphtheria, and pertussis vaccine. And they get one going into 5th grade, and then they get another one going into their senior year of high school. And the big problem is, after people get out of high school, they kind of forget about health care unless they're sick. If they're sick, they go to the doctor, but they don't typically go for their annual physical, which they should be doing. So, anytime I get a patient in the clinic, I ask them about their status regarding tetanus shot. Are you up to date on your tetanus? Because we want to ensure that they have one every 10 years at the least. All right, let's talk about hepatitis B vaccine. And this is generally given really young. The infant gets its first dose in hospital, and then it gets its second dose at 1 month of age, and the third dose, I'm going to have to look because I can't remember. Well, this drug is classified as an antiviral nucleotide reverse transcriptase inhibitor. So it inhibits the hepatitis B vaccine, HBV, that's what the vaccine is called, DNA polymerase reverse transcriptase by competing with the natural substrate deoxyadenosine triphosphate and causes a DNA chain termination after its incorporation into the viral DNA. Wow, that's a mouthful. It so what do you need to know? You need to know that hepatitis B works by causing your body to produce its own protection or antibodies against the disease. So if the body is invaded with hepatitis B, there are antibodies circulating within our um, circulatory system that will then go and bind with that so it doesn't cause illness. Let's see if I can find anything here. These are always interesting. Okay, patients who are at a higher risk, uh, persons at risk for sexually transmitted disease, incarcerated people, persons whose sex partner is hepatitis B positive, because this can be transmitted through sex, men who have sex with men, IV drug users, healthcare workers, dialysis patients, people with hepatitis C, travelers to countries with endemic hepatitis B, people with HIV, and persons with chronic liver disease. So we really want to ensure that we are immune to this, that we have been vaccinated against this. It's an IM injection. And of course, if there's a hypersensitivity to any of the components of the vaccine, uh, you would have to avoid using it, which is unfortunate, but it can happen. And let me get back here. I want to find out the age of the child. All right. Okay, I know it's 3 doses, but I want to know. Okay. Usually at 2 and 4 months. Okay. And some providers, that's true. I just saw this in my notes, dispense 4. So there are some providers that will dispense a 4 dose schedule: birth, 2, 4, and 6 months. I've seen that because I do a ton of sports physicals, and I review their immunization record, and I see that some have 4. But from all the references I've read, they don't need 4. Um, let's see. Let's look at this schedule. Yeah, 2, 4, and 6 months. So, I guess we'll have to research that one a little bit more. All right, here we go. HPV vaccine. um, we try to get kids vaccinated with HPV to help prevent forms of cervical cancer and anal cancer and throat cancer that can occur due to the HPV virus, right? And the HPV vaccine works like other ones. It stimulates the body to produce antibodies that bind with the virus and prevent it from infecting cells. Very simple, right? And HPV wasn't around when my kids were growing up. There was no HPV vaccine. Um, all right, let's look at the HPV schedule. Now, oh, goodness gracious. All right, HPV is administered as a two-dose series um, for most people who initiate the vaccines between the ages of 9 and 14. So if they get the dose between 9 and 14, they get the dose, and then 6 to 12 months later, they get a second dose, they're done. If they are over 14, now it's a three-dose series at 0, 1 to 2 months, and then 6 months later. And this is for people aged 15 through 45. So this is a rather new um, thinking process. When HPV vaccine first came out, they said no, it's no good for anybody over the age of 25. Done. Well, then they found out that yes, you know what? A lot of people are exposing themselves later in life, and you can transmit this through oral sex, anal sex, vaginal sex. So we changed it and made the schedule for adults, and in hopes that this is going to um, decrease HPV vaccine, or not vaccine, cases. And it can cause rectal cancer, which is really, really hard to treat. It can cause throat cancer, which is really, really hard to treat. And it can cause cervical cancer, which again is hard to treat. So we want to ensure that we are having these hard to say conversations with our patients. So I've been doing this a long time, so there is no hard to say conversation with me because I've said them all. I have no problem sitting down with a patient, asking them what their sexual preference is, if they identify as a man, woman, or something else. Believe me, that does not bother me one bit. I've been in nursing way too long. I've seen too many things. But so talking about their HPV status is just part of the exam for me. Talk about immune globulin serums. All right, so immune serum globulin, or ISG, is obtained from the plasma of a pool of healthy donors, and it contains a mixture of immunoglobulins, mainly IgG, with lesser amounts of IgM and IgA, and it's used to provide passive immunity for a variety of diseases like hepatitis, measles. So, for example, in the hospital, if we had a mother who was positive for hepatitis B and she was pregnant and delivered a baby, we immediately gave the baby a dose of immune serum globulin. That protected the baby from developing hepatitis B later on. And then we also immunized the baby right then and there, too. So if you have been exposed to a disease, if you get an injection of these serum globulins, hopefully you will not get the disease. Um, An important factor to note is that if the patient has a medical history of an immune system problem, like immune globulin A deficiency, or a bleeding blood clotting problem like low platelets, hemophilia, or kidney disease, it may cause issues with um, with giving them this medication. So it's something to be aware of. Now let's talk about one thing that you don't think about so much, but RhoGAM is an immune globulin. RhoGAM is a substance that we administer to women who are Rh negative. So, pregnant women who are Rh negative will create antibodies against the baby if the baby has positive blood, and the baby will suffer adverse effects, sometimes even death. Well, we have learned throughout the years that if we give mom a dose of this immune globulin, then it won't happen. Now, the first pregnancy is always safe. It's subsequent pregnancies. So after the first pregnancy, mom would get a shot of this immune globulin called RhoGAM, and then at 29 weeks, she'll get another dose, and no effects will occur because of mom's Rh negative status. And that was a huge thing that has occurred. That's really, I mean, in the years past, patients were advised to only have one child. It was really a challenge for people who were Rh negative to have healthy pregnancies. There aren't any interactions with drugs, and I think we've talked about the clinical use of these products. Tuberculin purified protein derivative. We've all had it. This is what is used to it helps diagnose TB infection in patients who are at risk. And as healthcare providers, we are at risk. The tuberculin purified protein derivative, or the TB, needs to be refrigerated. And what is the mechanism of action? All right. So the PPD interacts with toll-like receptor 2 expressed on APCs that initiates an inflammatory response. So let me put that in language that you may understand. If you've been exposed to tuberculosis, you have TB antibodies floating around in your body. Now, that doesn't mean that you have tuberculosis. It means that you've been exposed to it at some time or another, right? You get an injection of this tuberculin purified protein derivative, and the next thing you know, you've got a red spot the size of a $50 on your arm. Well, that's a positive TB. If you develop a positive TB, you need to go in and get um, either a blood test, quantiferin gold, or a chest x-ray to identify whether or not you have active tuberculosis. A lot of time it's not active tuberculosis. It just means that you were exposed to it at some time in your life. But we that's what we use for it all the time. It's it is very commonly used. Now, who shouldn't use it? Well, in many countries, patients are actually um, given a TB vaccine. So, like in Mexico, in Eastern Europe, those people all have been given a TB vaccine. So, guess what's going to happen if they get a TB test? It's going to be positive. And that doesn't mean that she has tuberculosis. It just means that she was vaccinated. But she still needs to go and have the quantiferin gold and the chest x-ray to confirm that she doesn't have active TB. So the medicine is injected in the forearm, and the patient has to come back 48 to 72 hours after the dose was administered for us to check the skin. And there are little graphs that you can get that will show you, if you put it on images on Google, it'll show you what an active tuberculosis looks like, or a positive. Now, there are different characteristics. If you're a healthcare worker, it's allowed to be bigger than if you are not a healthcare worker. So, if you have an opportunity to look at that chart of the size of the induration, uh, please do so. I think you'll find it very helpful. Talk a little bit about immunomodulators now. Immunomodulators stimulate or suppress the immune system to help the body fight different disease processes like cancer, infection, or other diseases. Immunomodulators can work to calm the immune system over an extended period of time as well. So, the immunomodulators can either stimulate or suppress the immune system. And we're using so many of these now. It's just absolutely amazing um, how many immunomodulators we're using today. Okay, I messed up on the other slide, so it stopped recording. So I just had to make another slide. So remember what I said, immunomodulators can modify and regulate the immune mechanism by either stimulating or increasing immunostimulants, or suppressing or down regulating immunosuppressants through various immune cell functions. And it's quite complicated. But for example, some autoimmune disorders, through years of scientific evaluation, it's been identified that in some immune system disorders, patients have elevated T levels, really, really high levels of T. So they came up with this DMARD, which is what we used to call them, but it is a immune modulator to suppress T cells, and the patient feels a lot better. Um, and Humira was a drug that did that. Oh gosh, there's a ton of them on the market today that work for just about, oh my gosh, so many different illnesses they're using these immunomodulators for. Let's see if we can come up with some examples of the commonly used ones. Plaquenil is actually one. Methotrexate is actually one, and not one that you would typically think were um, an immunomodulator. So, with respect to the different types of immunomodulators, they can roughly be divided into about 4 different categories: checkpoint inhibitors, cytokine agonists, and adjuvants. I don't know what adjuvants means, but that's the 4 that they can be um, turned into, or I mean, are function. Dupixent is an immunomodulator. It treats atopic dermatitis really well. Other ones, let's see. And these are targeted. So, a targeted immune modulator is a biologic response where it goes after what's causing the inflammatory process, like rheumatoid arthritis, ankylosing spondylitis, those things. I had already mentioned Humira. I don't think Humira is being used as much as it used to be. It was like super popular back in the 2010s. But I think you know though what I'm talking about. Here's a couple: Enbrel, Remicade, Nucala, Xolair, um, Orencia. So they're being used a lot for asthma too, um, atopic dermatitis. I mean, just a ton of things. A lot of monitoring needs to go along with these medications. Before the initiation of treatment, they need to get a TB test, and they also need to have any live attenuated virus or vaccines that they need. Okay. because once they go on these medications, they may not be able to build a proper immune response to develop immunity from these immunizations. Okay, so they should get those as well. Um, Also, with the suppression of their immune system, they need to be very cautious because they're much more likely to catch illness. They're much more likely to get TB. So they really need to be conscious of their environment. Um, I was on Humira for 5 years. My doctor used to tell me, I'm not afraid of you getting sick. I'm afraid of you getting sick and me not being able to get you better. So because when I was on immunosuppressants, when I would get sick, I would be sick for a month because my body couldn't build a good enough immune response to get me better. So there's downsides to these things too. At the time that I was on it, it was a blessing to me. So I took that risk and went ahead and used it, and it was wonderful. So lots of things to consider when we're talking about immunomodulators. I believe them to be the future. I've been saying this for 10 years since they first came out. I have a dear friend of mine who works in pharmaceuticals, and she represents one of the immunomodulators, and they are actually coming out with even more advanced treatments that go beyond immunomodulators. It's just amazing. So I hope that this presentation helped you to understand a little bit about vaccines and things like in the immune system. If you have any questions or concerns, please let me know. Otherwise, um, on to the next one.